We are live, sir.
Okay, we are starting. Ma'am, we are starting.
The 1 minute. Yes.
So very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar organized by the TNFOG on the topic contraception. I welcome the chief guest, speakers, and all the delegates who joined here for today's evening. I would like to take my pleasure to welcome the Master of Ceremonies for today's webinar, Dr. Gayatri Ma'am. Madam is currently the consultant at Shambhala Nursing Home, Trichy, executive member of Trichy OG Society. And Madam has presented various papers in AICOG and other chapters in AICOG. So with this short introduction, I welcome you, ma'am. I'm handing over session to you for the proceedings. Welcome, ma'am.
Thank you. Thank you for the introduction, sir. Let us proceed to today's webinar. As an overall welcome, I welcome all the delegates and the faculty for this wonderful webinar on contraception. Our everyday topic, which all of us need to be really very updated about what's all new in it. I would like to introduce the two main people, the brains behind all these things. Dr. Sampath Kumari, the secretary of the TNFOG, and Dr. Ramni Devi, who is the president. Dr. Sampath Kumari and Dr. Ramni require no introduction to this set of delegates and all the participants. Sampath Kumari Madam has been the Vice President in FOXI 2022. She's a Senate member, Tamil Nadu MGR University.
Gayatri, leave it. So I will introduce about the program, then we'll go with Tamil Thai.
Sure.
So good evening to all. Now I welcome you all for this Marathon CME. This Marathon CME is the CME conducted by the Tamil Nadu Federation. It is conducted on every month, second Friday. Last Friday being the Saraswati Puja, this month we are conducting on the third Friday. See, we have 3 sessions. One session for the Yuva. The Yuva will give talk for 15 minutes and they will be judged by the permanent judge, and at the end of the year in the annual conference, the best Yuva speaker will be awarded. And the update on this particular, we have a particular theme, and the update will be by the senior doctors in the second session. And after each session, one question will be asked. This is to encourage the delegates. The first answering delegate will get the prize, and third session is the panel. For the update and panel, we have the questions that MOC will project the questions through Sahiti. So that is the reason it is called as Marathon CME. Now I welcome our chief guest, Dr. Atul Munshi sir, and our president, Dr. Ramani madam. And Gayatri, you can proceed with Tamil Thai.
Sure, ma'am. Thank you, sir.
Gayatri, straight away we will move on to the welcome address, Gayatri.
Sure, ma'am. I request
Okay.
our President, Dr. Ramani Devi, to introduce our chief guest and welcome the gathering.
I have great pleasure in welcoming our senior most Foxian and a good friend of us, Dr. Atul Munshi. Can I have the CVF, sir? Sagiti?
Madam, in short only.
Yeah, short only. He is
Yes.
a senior consultant of Munshi Group of Hospitals, former HOD at GCS and NHL Medical College, Ahmedabad, editor-in-chief of Journal of Midlife Health, and IMS representative to Asia Pacific Menopause Federation, IMS representative to International Menopause Society, Foxy representative to SOFOX, chairperson of ICOG in 2014, President IMS, and Senior Vice President of Foxy, President Ahmedabad OBGYN Society, and in the editorial board of Pediatric On-Call Journal. And he has contributed many journals and international publications, and he has done a lot of work in menopause. So with this introduction, we are really lucky to have Dr. Atul Munshi as a guest of honor for this marathon CME. And I have the great pleasure of welcoming all the other people who are involved as faculty in this important session of Marathon CME on contraception, which is the need of the other. Our judges, Dr. Shanti and Dr. Kartika Prabhu, and the speakers, the Yuva speakers, Dr. Arvind Santosh and Dr. Jayalakshmi, and as well as a talk by an update on implant by a senior assistant surgeon from Avinashi, Dr. G. Ramya, and a nice panel that will be moderated by Dr. Geeta on the contraception in special situation. Because routine contraception we cannot use for everybody. It has to be individualized. I think she'll be having a very good session discussion with all her eminent panelists, Dr. Mahalakshmi, Dr. Sujata, Dr. Mahalakshmi V, and Dr. Shobana, and Dr. Leena. And with all this, any program will not be a successful one without the involvement of the participants. I have great pleasure in welcoming all the faculties as well as the delegates for this important marathon CME. Sir, over to you, sir. I would wish you to give pearls of wisdom for this important topic on contraception.
Good afternoon, Dr. Ramani Devi, Dr. Sampath Kumari, Mrs. Gayatri. It is nice to be part of this marathon webinar on contraception. I just heard what you are doing for every month. And that's a great thing, learning experience. We had a long association with Dr. Ramani Devi and Dr. Sampath Kumari. And all Foxia conferences outside also we are meeting again. So when she telephoned, I couldn't say no. So there's a conference going on of ICOG in Ahmedabad itself. We are witnessing a lot of progress in all fronts of our fast developing country. But unfortunately, progress is also there in population. This overgrowth of population do not allow for materialistic growth to be projected in right way. We need to slow down in this front. A lot of movement going on when I was student. Then it was the slow down. Again, it has taken up something. A child should be born because she is wanted, and not because it cannot be prevented. That should be the motto in all childbirth. Proper judicious use of contraception is the answer. Today in this webinar on contraception, we will discuss all aspects of the topic, the use, the abuse, the myths and reality. And I'm sure at the end of this webinar, all of us, including the students, will come out with new insight as far as contraception is concerned. I give greetings from Ahmedabad and welcome you all. And I wish you all a happy Diwali in advance. Thank you very much for involving me in this. Thank you very much.
Thank you, sir, for your kind message. Thank you so much. In spite of the ICOG conference being held, going on at Ahmedabad, you have, you have been kind enough to spend few minutes with us. We are really honored by your presence, sir. Thank you.
Thank you.
This is for World Contraception Day. It got postponed and today we are conducting, sir. Okay, sir. Thank you so much for accepting our invitation. Gayatri, you can proceed with
Yes,
the scientific session.
Thank you very much. Thank you, eminent guest of honor and our faculties. With this, we'll move on to the Yuva
Chief
session.
guest, not guest of honor, Gayatri, chief guest.
Yes.
We don't have guest
Chief
of
guest,
honor.
fine. Yeah. With this, we'll go to the first session, which is the Yuva session, where we'll have two Yuvas participating and giving their talks, and we'll have two professors who will be judging them. For judging them, we have Dr. E. Shanti with us, who is a professor in Savita Medical College and Hospital in Chennai. And she is an alumni of MMC. She did her MBBS and MD from there. She's also trained in ultrasound in OBG. She is trained in advanced infertility, laparoscopy, and she also provides, she's a provider and the instructor course. She has more than 25 publications to her credit. Her field of interest include endoscopy, high-risk pregnancies, adolescent gynecology, and she has been an examiner for the UG and PG, and she's also an invited faculty in a lot of conferences and has been involved in the organizing team in a lot of national and international conferences. Thank you for being with us, ma'am. With her, to judge the Yuva, we have Dr. Kartika Prabhu. She is a professor from the SRM Medical College, Chennai, Potteri. She is also finished her MBBS from MMC and her PG from JIPMA, undergraduate and postgraduate teacher with a special interest in high-risk pregnancies, gynec endoscopy, and midlife health issues. She has many awards to her credit. To mention a few, she has been the achiever of a A.V. Umayashu Memorial Gold Medal, Asha Bakshi Award from the annual conference, the AACC RCOG 2016 for a paper presentation. She's also received the A.L. Mudaliar Traveling Fellowship Award, has a lot of publications in the national and international journals to her credit, and she's also been a faculty in national and regional conferences. Now over to the two judges to introduce your Yuvas and start the session.
So our first speaker is Dr. Aravind Sandosh, who has done both MBBS as well as MS from Madras Medical College. He is currently assistant professor from IOG. So he is going to talk about male contraceptive methods.
Yes, ma'am. Thank you for inviting me, madam. Thank you for having me. Can I share my screen?
Yes, sir. Yes, sir. Go ahead.
Is it visible now?
It's visible, but it's not in PowerPoint.
No, I have already put it on. I think my screen sharing is paused. 1 second. I am not able to resume my screen sharing. Actually, there is some issue here.
Sir, stop share and reshare it once, sir.
Yes, I can. I'm stopping it now and I'm resharing it again. Just a minute.
What happened, Arvind?
Yes. Now, can you see me?
Perfect, sir.
Okay, yes, ma'am. So, good afternoon and good evening to everyone. So, I'm going to talk about male contraception. So, I'll welcome you to the Family Welfare OP of Institute of Obstetrics and Gynecology. So, this is going to be the first thing which we see in any family welfare clinic, the basket of choice. But what is exactly in the basket of choice? We have Malayan, we have the Implanon, we have Antara, we have Sencroman, we have POP, we have OCPs, we have the emergency contraceptive condom and the IUCD. So what options do men have and what options do women have? So if you see here, vaginal rings, spermicides, pills, IUCD, tubal ligation, injections, implants, diaphragms, patch, sponges, all of these are for women. And for men, we have only the vasectomy and the condom. So like my favorite comedian says, it is not enough. We need more options for men. So let me go from what is known to what is new while covering this particular topic. So let us talk about condoms. Condoms are the universally available method of contraception, and it was designed with the idea of safe sex in mind to prevent venereal diseases. It is actually a thin, flexible sheath over a man's erect penis. It acts as a barrier between the partners. The Pearl Index is 18 for typical use and 2 for perfect use. Now, how did the condom originate? If you go to the history of condoms as a timeline, it was first mentioned by the Egyptian men in 1000 BC who wore linen condoms to prevent infectious diseases rather than to prevent pregnancy. Around 100-200 AD, there was evidence of condoms in the European cave paintings. And in 1500 AD, Italian researcher Fallopius actually correlated the concept of prevention of infection and pregnancy to condoms. Till then, condoms were made using either linen or sheep, lamb, or goat intestine. Until 1844, Charles Goodyear discovered the process of vulcanization, which led to the development of strong rubber condoms, cervical caps, and cervical diaphragms. After this, in 1861, we have the first US print advertisement for condoms in the New York Times. But this led to a small problem with the church and other religious associations, which put pressure on the US government, and then Comstock law prohibited advertisement for birth control, and it also gave the postal service the right to confiscate condoms. After this, in the year of 1880, the first bladder condoms were produced, and over a period of the next 20 years, we see that the US troops were actually prohibited from using condoms. And this resulted in 70% of sexually transmitted diseases, which led to Franklin D. Roosevelt ordering to distribute condoms to the troops. If you look into the post-war era, post-World War I and World War II era, in 1942, condoms were issued to the US troops so that they did not bring home any STDs from their foreign tours. After the World War, we had a huge decrease in the world population, and we had the free love movement, which did not encourage people to wear condoms, and that led to a lot of increase in population. In 1977, US Supreme Court made sure that even minors can buy condoms. And with that, we come to the era of HIV, where in the 1980s, the Surgeon General mentioned that other than abstinence, the most effective way to prevent against HIV was using a latex condom. So this is how condoms have been introduced and developed over the period of time. And now we have condoms which are flavored, polyurethane, and delay lasting for a lot of other purposes. Now, condoms are mostly used by latex, but for men with latex allergy, we have polyurethane condoms. But polyurethane condoms have a higher slippage and breakage rate, which is 8.4 versus 3.2% in comparison to a latex condom. And there is also a risk of failure due to incorrect method, breakage, and slippage. Also, this requires a usage of water-based lubricant, and other lubricants and oils are not recommended because they can lead to condom breakage and thereby lead to the failure of the condom. The disadvantages is that it can break if it is stored for too long or exposed to sunlight or heat or humidity, and even while being packed in a very tight area like a wallet or purse, it can also lead to a poor quality of the condom. So next, we go to vasectomy, the next most commonly known method of male contraception. But this is actually a method of permanent sterilization, which has two methods, conventional and a non-scalpel vasectomy method. So conventional method is actually based on either a bilateral or a single midline incision, and there is an incision which is closed after doing a vasectomy, where 1 centimeter of the vas is removed. Anesthesia is given by local anesthesia for skin entry and a vasal block. Now, the non-scalpel vasectomy, after being developed in 1972 by Dr. Lee in China, has almost replaced the conventional vasectomy. Male sterilization rate is around 1.1% of all sterilizations in India, meaning the remaining 98% of sterilizations done by only female sterilizations. NYC was introduced in India in around 1992 and was incorporated into the national program in 1997. So this has a no incision and no stitch. And the NSV with facial interposition is the gold standard of sterilization for men. And the concept of excising a segment of vas has been questioned in a newer concept of vasectomy called the inline vasectomy, where the tube is either crushed or cauterized and a small amount of fascia is placed in between without necessitating to cut the vas difference. This is the procedure where we hold the vas, spermatic cord, we put a stab incision, we deliver the tube vas difference outside, and then cut and ligate the vas difference and reposition it into the scrotum and apply a pressure bandage. Now, there are problems. The unique problems of vasectomy are basically vasectomy regret and vasectomy reversal. Men who were in an unstable marriage or had no children or very young children while they had vasectomy, or when they had vasectomy during a financial crisis or pregnancy, had this vasectomy regrets. So providers have to ask patients or men who are coming for vasectomy and identify if they belong to any of these subgroups. And patients who want a remarriage or had death of children or desire more children, they go for vasectomy reversal. The most common method is vasovasostomy, which has a success rate of 70%. And if that is not successful, the next step is going to be a vasoepididymostomy, which is a difficult procedure which has only 10 to 30% success rate. There is also a problem that during vasectomy or during vasectomy reversal, there can be exposure of the sperm antigens to the blood, thereby causing anti-sperm antibodies, which can further inhibit fertilization after the reversal procedure also. So now let me talk to you about the newer methods. We have newer methods which can block or interfere with the sperm protection, which can block or block sperm to be produced and to be deposited in the vas deferens and the vagina, and other methods which affect the sperm maturation inside the male and the female's body. Methods which block or interfere sperm production, they can either prevent sperm production per se or can produce non-functional sperms. So this can be accomplished by hormonal, non-hormonal, or thermal methods, and their effectiveness can be seen or assessed by sperm analysis. But the problem here is spermatogenesis takes 70 days to happen. So this drug has to be taken for approximately 3 months before, so that we can see any effect, any use after that. So this has to be taken 3 months before hand, so that they can get a zero semen in the semen analysis, zero sperm in the semen analysis. So hormonal methods, these are basically steroids which interrupt the HPG axis and block sperm production. This was actually identified in anabolic steroid or bodybuilders who used androgens, and they ended up with infertility. So this here is not going to be a complete androgen, because complete androgens can cause side effects of anabolic androgens. Thereby, we have a combination of androgens and progestrogens to suppress LH and FSH, which impacts testosterone production and sperm production. But does this lead to a decreased or abnormal testosterone level? No. This is because the contraceptive itself contains testosterone or related androgens, which can maintain the level of androgens in the body, and thereby not causing any side effects. Now, there was a particular study which was actually stopped in the trial was stopped in between due to some side effects in this kind of hormonal drugs. The side effects which were actually mentioned were mood disturbances and acne. But if you compare to other, these are the side effects which I mentioned here. But if you compare to other drugs trials for OCPs and other contraceptives for women had to endure much more severe side effects, and the trials were not stopped at all at any point of time. But for men, just two minor inconveniences like mild acne or depression led to a complete stop in the trial. The funny aspect was 70% of the men who had those side effects were willing to continue the drug and continue the trial, but still the trial was stopped in between. That trial was for the drug Nestone gel, but now Nestone has been converted into a better, safer formulation. It's just a transdermal gel which is applied once daily in the shoulder or the arm. Other drug is going to be dimethandrolone undeconate, which has both androgenic and progesterone activity, and it's an oral and injectable drug. The next most common drug which we can expect in the market is going to be the Nestone gel. It is actually in phase 3 trials, and it has been approved in many other countries for phase 4 trials. Now, non-hormonal methods include proteins which involve in the sperm production, release, or function. These drugs block the sperm proteins, but the problem here is they have to be bioavailable into the testis. That means they have to cross the blood-testis barrier. So, drugs in clinical trial are electronic acid receptor antagonist, which is in phase 1 trial as of 2023. Tripnotide, a Chinese traditional medicine drug, mechanism of which is not very clear, and BRDT inhibitor. Moving on to thermal male contraception, we all know that heat causes infertility. So prolonged testicular heat reduces sperm count, and this was actually considered as a method of birth control in 1968 and 1990. And various devices have been used, like hot baths, artificial hypocalcism, thermal insulation of testes, heating underwear, and silicone ring. But the problem was there is a theoretical risk of testicular cancer, and the method to properly assess how much this creates sterility or contraception is not studied properly. So there are certain examples. We have a silicone ring which is kept around the testis, which causes thermogenesis and thereby causes sterility. There is technicals. This COSO is actually a bowl which the male will dip his testis, and the water around this bowl will heat at a higher temperature, thereby causing decrease in sperm production. And we have underwear which can cause increased temperature in the scrotum, which can also cause decrease in sperm production. The next method is going to be methods which block sperm release. So these are going to be either physical or chemical. The advantage is this can be effective on demand. I mean, meaning that they can be taken when they want contraception and not 3 months before. They are non-hormonal drugs, vaso-occlusive contraception, and barrier methods. Non-hormonal drugs are basically alpha-1 antagonists like tamsulosin and psilocybin, and P2X1 antagonist. The P2X1 antagonist is just theoretically conceptualized and it is still in development. The vaso-occlusive contraception, which is being studied in trial in phase 3 trials, are going to be RISUG, ADAM, and sperm switch. RISUG is actually the reversible inhibition of sperm undercarriage, which is developed in India by Professor S.K. Guha and IIT Delhi. It is an injectable vaso-occlusive gel, which is highly effective. It has been highly effective in multiple phase 3 trials. And is waiting for approval from DCGI in 2022. This is actually going to be 2 chemicals, sterling malic acid, anhydride, and dimethyl sulfoxide, which is going to be injected into the vas deferens. And this is a positively charged gel. This will physically block the sperm, and also the positive charge will also inhibit the negative charge of the sperm and neutralize it. This can be reversed by flushing the polymer out with another injection. ADAM is a similar hydrogel-based contraceptive, which is being devised in the United States. And here, the gel actually provides protection for 2 years, after which the gel degrades by itself. So there's no need to reversal. No need to do another injection for reversal of fertility. So this is how this injected into the vas deferens and prevents the sperm release. Now we have something called as a sperm switch. This is actually this concept was actually introduced by a person called Clemens Bimek, who's a carpenter. It's not a doctor per se. This Clemens Bimek in Germany had this concept where I can put a switch into the vas deferens where I can turn on and turn off the conduit. So this was introduced, and this person went to a doctor and they made this as a concept, and it is now being put in for phase 2 clinical trial. So let us go to the last method, which is going to be blocking of mature sperm, which is going to be affecting the motility of the sperm, capacitation, spermal liquefaction, and fertilization. So these are likely to be effective on demand, and they can be taken just before intercourse. And because this affects the sperm maturation, it can be taken by both men and women, leading to a concept called as a unisex contraceptive. So these are all drugs in the preclinical development, which is a soluble adenine cyclase inhibitors, EP055 targets, CATSPER14 targets, and PSA liquefaction targets. So these are all in early trial. We cannot expect this in the market anytime soon. But these are all points of interest, maybe like which some feel that both the men and the women can take to prevent pregnancy. So why do we need more male contraception? This question arises because we need men to take control of pregnancy and fertility and contraception. So I did a small study with many reproductively active men and women, and I asked them what are the male contraceptives they knew about. The condoms and vasectomy was the most universally known answer. Some people answered spermicides, and some people told coitus interruptus. The next question which I asked the men in particular, was if you have any option of taking a contraceptive pill, patch, or injection, would you do so? 50% of them were willing and they wanted to take the initiative, while 50% were not so forward and they wanted their girlfriend or their wife to take the contraceptive pills. I asked the same question to women, that if your partner has an option of taking a contraceptive pill or a patch or injection, would you want them to do it? And 2/3 of them want their husbands or the partners to take the lead in contraception, and only 1/3 denied that. So this is actually telling that we need more contraception for men. And I want to conclude with this particular patient. She is a 19-year-old unmarried patient. She came to, this person came to our family welfare clinic. This person was referred to us from RGGH, the transgender clinic. This was a 19-year-old person who is a biological female, but who identifies herself as a male. So they had gone to RGGH transgender clinic for a gender reassessment surgery. And during evaluation of surgery, during an ultrasound, they found out that this person is pregnant. And they referred the patient to our family welfare clinic for termination of pregnancy. And this particular person came to a government setup. The reason why I want to establish this is because we are now going to require more options for more people from more communities, including the LGBTQ+ community. And we need to widen our horizons, not just think about male contraception and female contraception, and think about contraception as a couple-based approach. Thank you so much for giving me the opportunity.
Thank you, Dr. Arvind, for our very elaborate discussion. I think the postgraduates would have benefited much from the recent advances. You have discussed everything in detail.
Thank you, ma'am. Thank
Suppose
you.
a patient undergoes is planning for vasectomy. So what counseling you'll give for the patient?
So when the patient undergoes vasectomy, we will have to tell them that patient would have undergone spermatogenesis and there is going to be some amount of sperm in the vas deferens, which can come out after the vasectomy. So the patient has to take a barrier contraceptive for at least 2 to 3 months after vasectomy, and only when they have come for follow-up and the semen analysis shows us there is no sperm, can they be completely sure that the vasectomy is successful. And that is only when they'll get the vasectomy certificate also, when they're doing it in a government setup.
The usual question will be like regarding the complications, right? The patient usually will come with those doubts, right? That also you need to
Yes, ma'am.
see. So what is expected after?
Yeah, so vasectomy is actually a very, very simple procedure. So unlike a female patient, the vas difference is actually present in the scrotum. It is very subcutaneous. So it can be done under local anesthesia per se. And the NSP method, which is going to be just a small stab incision, and the vasectomy is going to be done in less than 30 minutes. The patient can return to normal activity within 1 to 2 days and can start lifting heavy weights after 1 week of surgery. So this is not going to be causing any other side effects or any other symptoms. This is not going to cause impotence. They're not going to be having any erectile dysfunction or anything per se. This is just a small ligation of the tubes, and which is not going to have any future side effects regarding their masculinity also. So this is the most important aspect which we need to talk about, because men are afraid that their masculinity will be affected by doing a vasectomy. It is not at all so. And it is much more easier for them to undergo vasectomy in many conditions where the patient would have had multiple surgeries, the mother would have had severe complications due to delivery. They might even have severe cardiac lesions or other lesions which may prevent them from or put them in MEC4 of 4 for sterilization. In that situation, getting a surgery for the husband is much more easier. We have had patients who underwent even gastric bypass, gastric pull-through surgeries, so much of multiple 4 or 5 surgeries they have with multiple additions inside. Even then, the husband will not be willing for going for a vasectomy. So we'll have to. These are the patients who need to sit them down as a couple, tell them that your wife is at risk for so much, and she has already done so much with her body. You have to take responsibility, and that is why the entire concept is we need more options for men, because vasectomy per se is a very permanent procedure. So if something like an RISUG or a vasogel or some large alternative for men comes up, it is much more easier for them to choose that also. Because we have now Implanon, which is the government setup, and we have more women taking up Implanon, which is a long-active aerosol contraceptive. So that option for men is not yet studied properly. I think the Nestron gel, which is the next most, I think that will come to the market very soon, the next 1 2 years. That will be a very good alternative, because just a small spray over the shoulder or the arm every single day, once a day. So I think that is what we should move towards contraception for. It's not just going to be this male person or the female person. As a couple, they should start taking responsibility for contraception. It is not going to be just the women. The men also have to be taking the responsibility for it.
Thank you so much, Dr. Arvind. It was a wonderful deliberation done by you. Thank you so
ma'am.
much.
Thank you so much.
So may I invite the next speaker, Dr. K. Jayalakshmi. She is a consultant obstetrician and gynecologist from Sri Balaji Hospital, Salem. She has done her MBBS at Tirunelveli Medical College and her post-graduation at Kasturba Medical College, Manipal, and DNB at Sri Ramakrishna Hospital, Coimbatore. And she is a member of Royal College of Obstetricians and Gynecologists. And she has had many memberships in IMA, FOGSI, and PCOS Society of India. And very good, very nice to know that she has had the gold medal in Yuva FOGSI South Zone Conference 2011 for paper on recurrent pregnancy loss. And adding on to that, she's presented a paper on benign tumor mimicking malignancy in International Live Robotic Surgery Workshop and Masterclass in Gynec Onco at Kochi 2015. And also presented a paper on acute myocardial infarction in 3rd trimester of pregnancy, a case report at Justosis 2020. And her field of interest is in high-risk obstetrics and endoscopy, and has had an experience of 12 years. So may I welcome Dr. Jayalakshmi.
Thank you, ma'am. Thank you for the introduction. I thank all of you for giving me this opportunity. I'll be sharing the slides, ma'am. May I know if it is visible, ma'am, the slide?
Yes, ma'am. Yes, ma'am. Please go ahead.
Okay, thank you. So I'll be discussing about the hormonal methods of contraception in female. So why are we talking about the contraception now is the world population has reached 8 billion by 2024 and India is accounting for 17% of the world population. So contraception being the need of the hour, we have found half of all pregnancies in India are unintended. And we know we are meeting out with many maternal mortality, with many abortions. People come with unwanted pregnancies. They don't follow the birth spacing, and we intend to have many complications with that. So if unmet need for contraception was met, we can avoid many unwanted pregnancies, abortions, and of course, the maternal deaths. So the contraceptive use among married women in India, when they know about it, 94.5%, they actually use around 50.2%. And more than 1 in 10 married women in the developing world want to avoid pregnancy, but they are not using contraceptives. So there are some reasons why they are not able to take a decision to accept the contraception. So women need counseling, information, and a range of methods to choose from. So way back how there was the development of hormonal contraception from 1960s, the first Envoy 10 was introduced in the US by Searle, and Ann Ovalar is introduced in West Germany, and the first oral contraceptive in Europe. And then in 1970, the mini pill came into effect. 1980s, the biphasic pills, triphasic pill, and high-dose estrogen pill was being used. And 1990s, the low-dose oral contraceptives were introduced. And 2000, the extended and continuous regimen allowed women to experience fewer or no yearly menstrual cycles, and newer progesterones came into act. And 2010, the use of natural estrogens, 17-beta estradiol and estradiol valerate, was used in the combined oral contraceptive regimens. So timeline for the development of contraceptive methods from 19th century, from the older method now to the 2022 accepted Mirena, which is extended duration of up to 8 years. There have been a long time where there has been a development from many pills which are containing both combined hormones, estrogen and progesterone with high dose estrogen. Then there was reduction in the dose, and then the introduction of other newer progestins. With now we have 2 types of hormonal contraceptives: combined hormonal contraceptive and progestin only contraceptives. The oral contraceptives, transdermal patches and vaginal rings in the combined hormonal forms. And in the progestin only contraceptive, we do have progestin only pills, injectable contraceptive, implants, and intrauterine devices. So discussing about the combined hormonal contraceptives, these oral contraceptives are the most commonly used form of hormonal contraception, which has to be taken daily, started within 5 days of menstruation, usually with taken up to 21 days with a 7 days pill-free period, or for 24 days with 4 days of pill-free period. It is highly effective, regulates menstrual cycle, reduces menstrual pain, and lowers the risk of ovarian and endometrial cancers. But it needs daily adherence and not suitable for women with certain contraindications like history of thromboembolism or uncontrolled hypertension. So this shows the development of oral contraceptives with higher dose of ethinyl estradiol, reducing now to the low dose pills, and replacing with some natural estradiol valerate, estradiol hemihydrate. They have found the effect on BP has become lower with the newer estrogens. And the progestins have gone through 4 generations with more derived from testosterone to the ones with anti-androgenic effect. Now with the 4th generation, non-ethylated estrogens, Dinoges, spironolactone analog, drosperinone, pregnanes, it is normegestrol acetate. So there has been monophasic, biphasic, and triphasic pills with combined hormonal oral contraceptives. Monophasic pills contain the same amount of estrogen and progesterone throughout, and biphasic contains same amount of estrogen with the amount of progesterone increasing in the second half of the cycle. And triphasic, the amount of estrogen may be fixed or variable, and the amount of progesterone increases in 3 equal phases. Most commonly used is the monophasic pills, and these are the ones which are usually used with a higher dose of ethinyl estradiol in overall G, and most commonly with the 30 microgram ethinyl estradiol, which is available in the government setup, Mala N, Mala D, and to the lower doses of estrogen, and with the newer progesterones with anti-androgenic properties. The multiphasic pills with estradiol valerate and Dynogest contains the different dosage of estradiol valerate and Dynogest. Accordingly, with the 1 to 2 days, 3 milligram of estradiol valerate. From day 3 to 7, it contains 2 milligram estradiol valerate and 2 milligram of Dynogest. From 8 to 24 days, 2 milligram of estradiol valerate and 3 milligram of Dynogest. 25th and 26th day with 1 milligram, and 27, 28 day placebo, which is shown by the different pill colors. So what happened if there is a missed pill? If the one pill is missed, the one pill has to be taken as soon as possible, or 2 pills at the scheduled time, and rest of the pills to be continued each day at regular time. If 2 pills are missed, the 2 pills to be taken immediately and another 2 pills to be taken the next day, and the rest of the pills to be continued at the regular time. If there is more than 2 pills have been missed, discard the missed pills and continue taking the rest of the pills at regular time with the use of a backup method until the next period. So coming to the transdermal patch, which is most commonly the Evra, a small patch applied to the skin delivering hormones transdermally. It is typically worn for 1 week at a time, replaced weekly for 3 weeks, then followed by a patch-free week. The advantages are it avoids the first pass metabolism and provides continuous hormone release. And the consideration here is sometimes there is possibility of skin irritation at the application site. The vaginal ring, which is the usual one, is a Yuva ring, a flexible ring inserted into the vagina for 3 weeks and then removed for a 1 week break. It contains 2.7 milligram of ethinyl estradiol and 11.7 milligram of etonorgestrel, delivering about 15 microgram of estradiol every day and 120 microgram of etonorgestrel every day. So the advantage only requires monthly administration. There is steady hormone release with localized effect. And the consideration here is potential discomfort or expulsion, contraindicated in women with specific risk factor for estrogen-related complications. Coming to the progesterone-only contraception, the progesterone-only pills or the mini pills which are available, taken daily without a break, offering an alternative for those with estrogen sensitivity or contraindication. It has to be taken at the same time each day. There is advantages. There is lower risk of thromboembolism compared to the combined hormonal contraceptive and can be used safely during breastfeeding. The consideration is there is a need for strict adherence at the same time each day and slightly higher risk for irregular bleeding. We do have desogestrel containing pills, and the newer one is the drosperinone containing pills. So what happens when there is a missed pill? Levonorgestrel pill is if the pill is more than 3 hours late, that is more than 27 hours since the last pill taken. If there is 1 pill missed, take the next pill as soon as take the pill as soon as remembered. If there is more than 1 pill missed, take most recently missed pill as soon as remembered and discard any other previously missed pills. And take the next pill at the usual time. This may mean taking 2 pills on 1 day and continue taking daily. Consider emergency contraception for any unprotected sex from the time the pill was first missed until 3 consecutive pills are taken. And condoms barrier method used until 3 consecutive pills have been taken. For the for it to have the time of action. So drospirenone containing pill, if there is more than 4 hours since last pill taken, it is a missed pill. 24 to 48 hours since last pill, take the late pill as soon as remember and continue as usual. If it is more than 48 hours, then take the most recently missed pill and discard any other previously missed pills. And if it is less than 7 pills taken since the last inactive pill break, we have to consider emergency contraception if there was unprotected sex in the past 5 days. And less than 7 pills left in the pack before the inactive pill break, you can skip the inactive pills and continue with the active pills in next pack. So coming to the injectable contraceptives, the one which is available, the medroxyprogesterone acetate injection, which is administered intramuscular or subcutaneous every 3 months. The advantage is long-lasting effect with high efficacy and no daily adherence is required. The consideration here is potential for weight gain, bone density loss with prolonged use, and delay in fertility return after discontinuation. The implantable devices which are available as a small rod inserted under the skin of the upper arm. The implanon, which is single rod containing 3-keto-desogestrel with 67 milligram, and it prevents pregnancy with a life of 3 years. And Gerel with 2 sialistic rods containing levonorgestrel 70 milligram, and it has a life up to 5 years. So the advantage is highly effective with minimal maintenance, rapid return to fertility upon removal. The irregular bleeding is a consideration in this, requires minor procedure for insertion and removal. The next one is the intrauterine device, the levonorgestrel containing intrauterine system. The most common Mirena is a T-shaped device placed in the uterus, contains 72 milligram of levonorgestrel, releasing 20 microgram locally over a period of 5 years. And Skyla, which has 13.5 milligram levonorgestrel, releasing 14 micrograms daily for a period of 3 years. The advantage is the long-acting reversible contraceptive with minimal systemic hormone effect, and it also reduces heavy menstrual bleeding. It may cause some discomfort during insertion, spotting, or irregular bleeding may occur initially. So how this hormonal contraceptive work is mainly by preventing ovulation, disrupting the endometrium, modifying the cervical mucus, and not allowing the implantation. As we know from the hypothalamus, the GnRH is released, and from the anterior pituitary, the gonadotrophin, FSH, and LH acts on the ovary. This acts by suppressing ovulation. The combined hormonal contraceptives, the estrogen and progesterone, inhibit the release of gonadotrophin releasing hormone from the hypothalamus. The suppression of GnRH causes reduced secretion of FSH and LH. Without the LH surge, ovulation does not occur as the ovarian follicles do not mature and release egg. The progesterone-only contraceptives act by inhibiting LH secretion and prevents ovulation. While some progesterone-only methods may not consistently suppress ovulation, they employ other mechanisms to prevent fertilization and implantation. Both combined hormonal and progesterone-only method increase the viscosity of cervical mucus, makes it thicker, significantly reducing the sperm motility. Progesterone and hormonal contraceptive induce changes in endometrial lining, which becomes thinner and more atrophic. So it is less receptive to implantation by a fertilized egg. The progesterone component may inhibit the process of sperm capacitation necessary for the sperm to penetrate and fertilize an egg. A word on emergency contraceptive, which is the hormone available as a levonorgestrel 1.5 milligram, a single tablet taken within 72 hours of unprotected intercourse. With this high-dose progesterone, it delays or inhibits the ovulation if taken before ovulation occurs. And these pills do not prevent fertilization if ovulation has already occurred, and they do not affect an established pregnancy. Similar to regular hormonal contraception, these alter the endometrial lining to reduce the likelihood of implantation. And this is how all contraceptive methods work. Coming to the efficacy of hormonal contraception, with the perfect use versus the typical use. The perfect use reflects the effectiveness of a contraceptive method when used consistently and exactly as prescribed without any errors. The typical use represents how effective a contraceptive is in real-world condition where users may occasionally miss the dose or use the method incorrectly. So, importance of adherence. Hormonal contraceptives are generally highly effective, but adherence plays a critical role. Missed pills, late injections, or improper use of patches and rings can significantly impact the effectiveness of the contraception. So this picture shows the failure rates of various methods of contraception. What we are discussing in the hormonal contraception contributes here with the failure rate of 2 to 9 in 100. So combined oral contraceptives, progestin-only pills and transdermal patch and vaginal ring, with the perfect use, it is less than 1% failure rate per year. And with typical use, it's around 9% failure rate per year. So with combined oral pills, the adherence is a key as missing pills or inconsistent daily intake can reduce the effectiveness. And with progestin-only pills, there is strict adherence to the timing because it has to be taken at the same time. And with the transdermal patch and ring, adherence to weekly in patch or monthly when applying a ring impacts the effectiveness. So injectable contraceptive will have a less than 1% failure rate with the perfect use and about 4% in the typical use. Compliance with the injection schedule every 3 months is crucial. Late or missed injection can increase the risk of pregnancy. With implants, the failure rate is less than 1% in perfect and typical use, which is extremely effective. It does not rely on user adherence after insertion, remains effective up to 3 years. With hormonal intrauterine devices, the failure rate is less than 1% as it offers long-term protection with minimal user intervention leading to low failure rates. The factors which usually influence the failure rates are the user error, like missed dose, incorrect timing, improper application. Depending on the body weight and BMI, in case of the transdermal patch, the efficacy may be lower in those with high BMI. Drug interaction while taking pills, methods of suitability according to age, lifestyle, and personal health conditions. The comparative effectiveness of hormonal contraceptive, highly effective method with the failure rate less than 1%, the long-acting reversible contraceptive like implants and LNG IUDs. Moderately effective methods with failure rate 4 to 9% is combined oral pills, progestin pills, patches, rings, but have higher typical use failure rate due to adherence challenge. Emergency contraception generally used as a backup method with varying efficacy depending on timing of use relative to the intercourse. So clinical implications and counseling, we have to discuss the realistic expectation, emphasizing the difference between the perfect and typical use, and to understand the importance of adherence and tailoring the contraceptive choice. It should be a personalized approach considering many factors. Backup and dual protection may be needed to reduce the overall failure rates. So coming to the discussion on non-contraceptive advantage of hormonal contraceptive, they do have action on menstrual regulation and relief of...
Dr. Jayalakshmi, you are exceeding your time. You just
Okay.
tell the gist of it.
Yeah, okay, ma'am. So these hormonal contraceptives have been found helpful in regulating menstrual disorders and the treatment of hormone-related conditions and reduced risk of certain cancers like ovarian, endometrial cancer and colorectal cancer, and management of endometriosis by symptom relief, reduction in lesion growth, bone health, and reduced risk of anemia with decreased menstrual loss, improving iron stores, protective effect in cardiovascular and the common side effects with nausea, which is common, headache, migraines, breast tenderness, weight gain, mood changes, irregular bleeding, amenorrhea, venous thromboembolism, and cardiovascular events more common with estrogen-containing pills. So breast cancer, liver, gallbladder issues all have been found to be associated with estrogen containing pills. Bone density with the most injectable progesterone only is said to return after discontinuation. So the treatment of adverse effect is when there is breakthrough bleeding, we have to increase the estrogen dose or switch on to the other method. And the amenorrhea or irregular bleeding associated with injectable all can be reassured and the patient can be allowed to continue. So there is criteria for patient selection with the WHO, US and UK medical eligibility criteria. So choosing the right contraceptive when the woman is confused is important. So we have to have a framework for quality in contraceptive counseling, and we have to tell the importance of contraceptive counseling. We have to consider the medical history, consider the risk factors in the women. We have to understand the individual needs and preferences, assess the reproductive goal, evaluate the lifestyle and convenience needs, and depending on the menstrual changes, and if there is a need for other like fibroids or adenomyosis, and if they are ready to take self-administered method, we have to also have counseling on efficacy and contraceptive failure rate. Incorporating technology and digital tools will help in patient adherence. So coming to the summary, contraception is the need of the hour worldwide. Unmet need for contraception to be met for better results. Women should have proper counseling, information, and wide range to choose from. Choosing the right contraceptive is important, taking into account the medical eligibility criteria, also considering various factors influencing the decision making. Combined oral contraceptives are widely used, safe, avoided in women with contraindication. Progesterone-only contraceptives like pills are safer in breastfeeding women, and long-acting reversible contraceptive like implants and intrauterine device are long-lasting, reducing the frequency of administration. Thank you, ma'am. Thank you for this opportunity.
Thank you, Dr. Jayalakshmi, for your elaborate discussion. Suppose a patient is on oral contraceptive pill, you are planning major surgery. What precaution you want to do?
When the patient is on oral contraceptive pill, she's more prone for thrombotic event. So we'll advise to stop the contraception or switch over to another method and then plan the surgery. And we should also consider if we are planning it soon, then we have to consider about thromboprophylaxis.
Okay.
So anything about like medroxyprogesterone acetate subcutaneous? Because we are, I think our Foxy is trying to promote that.
Yes, ma'am. The medroxyprogesterone acetate is also sub-Q Provera is available, which is which contains 104 milligram, which can be self-administered subcutaneously by the patient. So if we counsel the patient and teach them, then there is more chance of patient adherence to that.
So that is one advantage. It can be self-administered. Yeah. Okay, fine. Okay, as you mentioned, it was a basket full of hormonal contraceptions. I think we can discuss about it the whole day, but then it was a wonderful compilation of all the details about the hormonal contraception. Good job.
Thank you. Thank you, ma'am.
Dr. Jay.
Thank you very much, judges and the presenters. It was quite, Ami madam, you are muted.
Yeah. I request all the Yuvas to keep up the timings in future. You are exceeding, all of you are exceeding.
Okay.
I think Aravind was in app time, he finished it.
Yes, ma'am. Thank you so much, ma'am.
Yeah, go ahead, Gayatri.
Okay, so with this, we come to the end of the Yuva session, and now we go on to the scientific session where we have Dr. Ramya waiting to tell us all the updates on implants. And we have Dr. Ramani Devi who is going to chair the section. So, madam, over to you, ma'am, to introduce our speaker, our expert.
Yeah, take off my. Yeah, I have great pleasure in introducing Dr. G. Ramya, who's a senior consultant, senior professor at, she's a senior doctor at Avinashi hospital, government hospital. She has completed her undergraduation from Coimbatore Medical College and post-graduation from Stanley Medical College. And she is a district trainer, sterilization, Antara, Chaya, IUCD, and she is a member of DQAC, and her areas of interest are high-risk pregnancy and adolescent health. And I should personally say that she has done a wonderful work during a COVID period, not skipping any duty, and continue to do her obstetric duty during the COVID period in her hospital at Tirupur. I think Ramya will be a best person to tell us something about the contraceptive implants that are available currently. Over to Ramya. Ramya?
Madam, am I audible?
Yeah, you are very much audible. You can go ahead.
Okay. Good evening, everyone. Thank you for the kind introduction, madam. So now our scientific session is going to be on implants. So next slide, please. So implants are excellent methods of contraception. They are actually long-acting, reversible methods of contraception. So they are small rods which are inserted subdermally and which release progesterone over a period of time. So this progesterone-containing implants, the release of progesterone can be levonorgestrel or etonogestrel. So the Norplant is a 6-rod system, Jadali is a 2-rod system, and you have Implanon, which is a single-rod system. Nexplanon again is a single-rod system. Implanon and Nexplanon are etonogestrel-releasing hormones, and Nexplanon is coated with barium sulfate and it is radio opaque. So you can detect it with CT, MRI or X-ray. So, and the next slide, please. So what are the key points which you should know? So what is it? It's a small flexible plastic rod which is inserted subdermally, preferably in the non-dominant hand in the inner upper arm. Okay. And the mechanism of action is it will block the sperm and prevent ovulation. The only thing is you require a trained provider for inserting and removing. And one more thing is the patient compliance. Suppose a patient in the periphery is coming to you and she's telling, I cannot come to the healthcare facility frequently. You please give me one contraception like that. Or an adolescent is coming to you, an 18-year-old adolescent, newly married. She's pursuing her college studies. She's telling, I want a contraception which will suit me. So for such patients, implants will be ideal. And nothing to remember after the insertion. It's very user-friendly. And since it's a progesterone, what you can expect is some changes in the bleeding pattern. And if there is a waiting time, you have to use condoms in a backup contraception. And one more thing, if you want protection from STI or HIV, you should use a condom. Next slide, please. Next slide, please. For the clients, what you're going to tell the client? It's a safe method. It's an effective method to prevent pregnancy, and it will last for 3 to 5 years. And it can be removed anytime. And one more thing is, the return of fertility is immediate. Suppose if you're giving a DMPA injection, the return of fertility will take 7 months. But with this contraception, the return of fertility is immediate. Next slide. Next slide, please. See, this is the thing showing the effectiveness. Implants is in the top. The efficacy is almost equivalent to male and female sterilization. Next slide, please. Next slide, please. So it is again showing you the failure rate. The failure rate is very less. The number of unintended pregnancies is very less compared to other contraception. So almost equivalent to permanent sterilization. Next slide. Next slide, please. So mechanism of action, I've told you already. Since it's a progesterone, it's going to make the cervical mucus thick. And one more thing is, it suppresses the hormones in the pituitary and hypothalamus. The LH surge will also be reduced. Next slide, please. So what are the benefits? As I told you, it's very safe and effective. It's actually 99.97. Fertility returns immediately. Breastfeeding women can use this contraception. See, breastfeeding women cannot take a combined oral contraceptive pill. And if you're going to give an injectable also, we tell after 6 weeks. But if you are going to give an implant previously, before 6 weeks also, then again it comes only under category 2. So it is even better. And non-contraceptive health benefits, like as with other any hormonal methods, like any heavy menstrual bleeding, if the patient is having a fibroid, adenomyosis, or an endometriosis where she's having severe dysmenorrhea, heavy menstrual bleeding, this will be an apt solution. And limitation is very few side effects. The only thing is you need a trained provider to insert and remove, and no protection for STI and HIV. Next slide, please. So the risk of PID is going to be very less, and to protect against iron deficiency anemia, reduce the risk of ectopic, and in heavy menstrual bleeding, estrogen-related conditions like fibroid, adenomyosis, endometriosis, all that, this will be an ideal contraceptive. Next slide, please. So side effects, so since it's a progesterone, you can have a little bit of spotting, little bit of irregular bleeding, infrequent bleeding. Sometimes they can have amenorrhea also. But if the patient is already anemic, this amenorrhea is going to be beneficial only. So the only thing is you need to properly counsel the patient before giving this thing. Next slide. Next slide, please. Next slide, please. So the progestin-related side effects can also be there. Headache, breast tenderness, lower abdominal pain, acne, weight changes, dizziness, mood changes, nausea, nervousness. So what are the complications you can expect? See, actually, when you insert it rightly in the right patient and when a right person is inserting it, complications are really very rare. Infection is very rare. If it's going to occur now, going to occur within the first 2 months. Difficult removal, if you're inserting it properly by a trained person, there will not be chances of difficult removal. Expulsion also, with a proper insertion, expulsion will not take place. Found in another place of the body, in a blood vessel, that is also rare. Only thing is a trained provider should insert it correctly. If you do it correctly, complications are very, very rare with implants. Next slide. So who can and cannot use the implants? Next slide. See, adolescent girl is coming to you. She's 18 years old and she's asking for a contraception. So counseling for IUCD will be difficult. They will not like it. For such a girl, you can offer this implant. And breastfeeding mother also, it is good. HIV infected, for all the classes, you can give implant. Even with non-protease inhibitors, for an HIV infected patient, it comes under only category 2. For all categories of HIV, you can give implant. Little access to healthcare, periphery the patient is living. For such a patient, you can give implant. And if they want to complete the family also, it's okay. You can give implant and you can get it reinserted. Next slide. Next slide, please, Gayatri. Next slide, please. So almost all the women can use implant, including whether they are nulliparous or multiparous, whether they are married or unmarried, whether they are an adolescent or above 40 years, whether if they are infected with HIV or breastfeeding, any abortion, miscarriage, ectopic, if they are anemic, if they have varicose veins, smoking person, all these patients can be offered implants. So most health conditions do not affect the safe and effective use of implants. So women who cannot use methods that contain estrogen can safely use implants. Next slide, please. So this is the medical eligibility criteria. You have to assess the medical eligibility criteria. Actually, for all patients you can give. Next slide. So category 1 is there are only advantages, no risks. Category 2 is advantages and risks are there, but still advantages are more. So category 1, adolescents, post-abortion, postpartum, non-breastfeeding women, heavy smokers, high blood pressure patients, valvular heart disease, endometriosis, even endometrial or ovarian cancer patients you can give, thyroid disorders, mild liver disease. And category 2C, see 6 weeks, less than 6 weeks postpartum, you can give implant. Multiple risk factors of cardiovascular disease, blood pressure more than 160/100, any history of thrombosis previously, diabetes with vascular complications, heavy or prolonged vaginal bleeding. Next slide, please. Gayatri, next slide. So category 3, you have risks and benefits, but risks are more. So when there is any acute thrombus, unexplained vaginal bleeding, breast cancer, history of breast cancer, severe liver disease, systemic lupus, Then in category 4, totally you should not give current breast cancer. Next slide, please. So mostly if you see, most of the patients you can prescribe as implants. HIV again, you see, all HIV patients can be prescribed. See, asymptomatic or mild HIV, severe or advanced HIV, ARV therapy with NRTs and integrase inhibitors will come under category 1. Non-NRTs and protease inhibitor is category 2. Again, you can use. You have risks and benefits, but benefits are more than the risks. And one more point is when you're giving efavirenz and the implant, the efficacy of the implant will come down. Then you have to use a backup contraception. So breastfeeding again, even for more less than 6 weeks, you can use this implant. It comes under category 2. So immediately postpartum, anytime you can give the implant. Next slide, please. So you need to checklist, refer the checklist, and then you have to give the implant based on the medical eligibility criteria. So when are you going to start implant? So first thing, for any contraception, you have to rule out pregnancy. If she's fully breastfeeding, no menses, babies between 6 weeks and 6 months, you can start. Abstain from intercourse since last menses or delivery, yes. Had a baby in the last 4 weeks, you can start. Start monthly bleeding within the past 7 days, yes. Remember the word 7. Had a miscarriage or abortion in the past 7 days. Then is using a reliable contraceptive method consistently and correctly. If none of the above applies, pregnancy can be ruled out by a pregnancy test, pelvic examination, and wait till the next menses. Next slide, please. Next slide, please. So post-abortion or miscarriage, surgical abortion immediately without backup in the first 7 days you can start. If it's more than 7 days, rule out pregnancy, use a backup for 7 days. So if a woman is undergoing a medical abortion, implant can be inserted along with the first pill of the medical abortion. You are switching from a hormonal method immediately if it was used consistently and correctable. So suppose injectable users are coming to you, they are telling, I want an implant now. They can have the implant inserted within the re-injection window itself. No need to wait for the next menses. Next slide, please. So emergency contraceptive pill the patient is taking. When will you give implant? So progesterone only or combined EC pill, implants can be inserted on the same day of the ECP. Use a backup method for first 7 days. Suppose if the patient is taking ulipristal acetate, implants may make one or more less effective. There will be an interaction. So implant should be inserted on the 6th day after taking UPA. Backup method for 7 days. Next slide, please. So this is again the chart showing the effectiveness. Implant's effectiveness is very high compared to the other methods. Next slide, please. Next slide, please. So this is again the menstrual bleeding pattern with a 2-rod system. Discontinuation rate due to menstrual change was 9% only. Next slide, please. For implanon users, the discontinuation rate due to menstrual change was 11.3%. Next slide, please. So no significant metabolic effects. So implanon, everything, no, that it has got no significant change in the lipid or carbohydrate metabolism, blood pressure, blood clotting, liver function. So obese patient, diabetic, hypertensive, she's coming to you for a contraception. She's telling, I can't come for a follow-up. You can give her an implant. So metabolically, it's very, very safe. Now coming to the procedure of insertion. 1-rod insertion is implanon. So what are the
Dr. Ramya, you are not audible, you are muted.
Am I audible now?
Yeah. You got muted almost when you started the slide, like how to insert.
Am I audible now?
Yeah.
So these are the things which are required. An examination table, a waterproof marker, a sterile surgical drape, antiseptic solution, local anesthetic, skin closure, sterile gauze and compresses, and the next applicator. All this is required for the insertion. Next slide, please. So this is the applicator. You have a preloaded implant from the package and you have to place it in the sterile tray without touching it. Next slide, please. Next slide, please. So So where will you place the implant? It has to be placed subdermally, and care should be taken that you insert it 3 centimeter below the sulcus between the biceps and triceps, avoiding the neurovascular bundle. So how we are going to mark the point is palpate the medial epicondyle, go 8 centimeter above the medial epicondyle, and 3 centimeter below the sulcus between the biceps and triceps. So this is the applicator. So what you're going to do is the position of the women is, so ensure that she has washed with soap and water. Patient has to lie on her back, flex the elbow, place it at the back, and then you palpate the elbow and mark it with a marker, waterproof marker. Then you place the, clean it nicely with an antiseptic solution, place the drape. And then you take, then you have to hold the applicator just above the needle at the textured surface area and remove the transparent protection cap by sliding it horizontally away from the needle. And do not touch the purple slider until you have fully inserted the needle subcutaneously, as it will retract the needle and release the implant from the applicator. Previous slide, I think you're a bit tired. So that is the purple slider. Don't touch the purple slider. So you have to stretch the skin around the insertion site with the thumb and index finger of the left hand. Puncture the skin with applicator at 30 degree. Insert only the bevel of the needle. Then hold the applicator, lower the applicator to a horizontal position and lift the skin with the other hand and slowly insert it. Be sure that you are in the subdermal plane. Then keeping the applicator in the same position, the needle will be inserted to its full length. Then after ensuring that it is in the correct place only, you have to unlock the purple slider by pushing it slightly down. Then move the slider fully back until it stops, leaving the implant in its final position and locking the needle inside the body of the applicator. Then you have to remove the applicator, leaving the implant in place. Next slide, please. Then you have to verify the presence of implant by palpating the site. And then make the women also to palpate the implant. Then apply a sterile gauze and wrap the arm with pressure band-aid. So this is how you insert the 1-rod system. And then coming to the 2-rod system. Next slide, please. So you the same equipment again. Next slide. Next slide, please. After all the strict aseptic precautions and everything. So here again, what you do is the disposable trocar has got 2 marks. The mark closest to the hub indicates how far the trocar should be introduced under the skin to place the rods. And the mark closest to the tip indicates how much of the trocar should remain under the skin following placement of the first rod. So you get all the sterile trocar and implants ready, open both packages carefully and allow the trocar and rods to fall on a sterile drape. You have to follow the no-touch technique. Next slide, please. So again, the same position. And one more thing, after the antisepsis and everything, marking the point and everything, here you have to mark it in the form of V, because at a 30-degree angle for inserting the 2 rods. And before insertion, insert a local anesthetic, 1 ml of local anesthetic, 1% solution, 1 to 2 ml, you have to insert it in the track. Next slide, please. So puncture the skin with the trocar and insert its tip beneath the skin at a shallow angle. Gently insert the trocar while lifting the skin. Failure to do so may result in deplacement of rods and could make removal very difficult. You have to be very careful to be in the right plane. Then advance the trocar to the mark nearest to the hub of the trocar. When the trocar has been inserted to the appropriate distance, remove the plunger and load the first rod into the trocar using a gloved hand or forceps. Gently advance the trocar with the plunger towards the tip of trocar until you feel resistance. Do not force the plunger. Never use force. So you have to hold the plunger stationary with one hand. Withdraw the trocar to the mark that is closest to the trocar tip. So withdrawal technique only we are using. Next slide, please. Then keep the obturator stationary. Do not push the rod into the tissue. Withdraw the trocar and plunger together until mark closes nearest to the trocar tip. Do not remove the trocar from the skin till both rods are removed. Both rods are inserted. Then again, slowly you turn it to 30 degree, advance and repeat the procedure on the other side also, and slowly you withdraw the trocar out. Next slide, please. Finally, you have to apply a sterile gauze and a compression bandage and pack it up nicely. Next slide. Next slide, please. So post insertion is you have to dispose the needle properly in a sharp container. Wipe the non-disposable instruments with a wet cloth. Remove any tissue or blood before further cleaning and processing. Dispose the waste materials like cotton gauze in leak-proof contaminator. Decontaminate the surfaces that may have been contaminated by blood with a 0.5% chlorine solution. Remove the gloves and wash your hands thoroughly and dry. Next slide, please. Next slide. So what are the instructions you will give to the patient? Inform her she can return if necessary alone. And you have to tell her, counsel her regarding the side effects, that spotting, amenorrhea and everything. If she's got any doubts, she can come back. Then implant can be removed anytime if she desires it. And observe the client for 15 to 20 minutes before sending her home. Give a client card with the details of date of insertion, batch number, everything. Next slide. Next slide, please. So the area should be kept clean for 48 hours. Can take off the pressure bandage after 2 days and the band-aid and surgical tape after 5 days. So any bruising, swelling at the insertion site is normal and will subside in a few days. You can start the routine work immediately, but avoid lifting heavy weight. After healing, the area can be washed and touched as usual. Next slide, please. Then again, the removal what we are going to do, one rod, removal of one rod. So again, you need the following equipments. Additionally, you require a forceps, straight or curved mosquito. So the position is the same. Inject and palpate the implant with your left hand. Push the implant down. You can feel the lower part of the implant. After injecting the local anesthetic, you can use 3 types of removal, a vertical incision or a horizontal incision or a inverted modified U technique. So make a small horizontal incision at the tip of the implant, push it down. So when you, next slide please, when you feel the lower end of the implant, catch hold of the implant with a mosquito forceps. If there's going to be a dense fibrosis over the implant, you need to dissect it with a small mosquito forceps or a scalpel and you can take the implant out. Next slide please. And then after removal, apply a compression bandage, check if it's bleeding, and then you have to seal it and pack it nicely. Next slide, please. And the 2 rod is also similar. Next slide. Instruments are the same. Next slide. So these are the instruments which are used. You can use a curved and straight mosquito forceps, a Kelly's or a Cryle's forceps. Next slide. Position and the local anesthetic where you're going to inject is at the base of the V. Little bit below the base of the V. Next slide. Next slide, please. And then a 4 mm in the incision should be very small, 4 mm incision, and try to catch hold of the implant. If there is fibrosis, dissect it and slowly remove it. If you're not able to catch hold of it, slowly introduce the forceps inside and try to catch hold of it. And if there's fibrosis, you have to dissect it with another instrument. And when it's very difficult, you can even use a vasectomy clamp and remove it with a modified U technique. Next slide, please. Now after removal, check for bleeding and apply compression bandage. And dispose everything as required. Wash hands thoroughly. Next slide. Next slide, please. And you have to tell the women regarding wound care and when she should return. And then you have to option. You have to, if she wants another method of contraception, you need to counsel her. Observe for 15 to 20 minutes before sending her home. Next slide. So if she wants it reinserted again, again you can reinsert. But if she wants to discontinue and if she wants to become pregnant, counsel her about other contraceptive options. Next slide. So the main thing is no routine visit is required. Suppose if you are inserting a cooperative, initially she needs to come for the checking of the threads. If you are giving her a DMPA, she has to come once in 3 months. Oral contraceptive pills she has to take daily. This is actually very user friendly and the compliance is actually very good.
Ramya,
So-
can you wind up? Can you wind up?
Okay, next slide. Next slide, Pa. So these are the things you should counsel. Irregular heavy bleeding, amenorrhea. Next slide. Next slide, next slide. Headache, abdominal pain, breast tenderness, weight gain. They're all progesterone related. They need just reassurance. Next slide. Infection abscess, all this is very rare when you introduce it properly. Next slide. Unexplained vaginal bleeding, migraines, blood clots, everything can be managed. Next slide. So proper infection prevention practices to be followed. Next slide. The summary is implants are an option that fulfills the unmet contraception for many women, provides a long-term protection, safe and easy to use, highly effective and readily reversible. It's appropriate for all women, young and nullipara. Little is required of the client once the implant is in place. Irregular bleeding patterns may be a problem for some women. Thorough counseling is essential. So, provision of contraceptive services is very important and it has got a long way to go in reducing the maternal and infant mortality and morbidity. That is why the Government of India and TNFOG has given importance to this topic. And implants has been started as a pilot project in Tamil Nadu in 2 districts at Erode and Dharmaburi. And within a short period, I think it will be available in the government sector everywhere. Thank you, madam, for the opportunity and patient listening.
Thank you, Ramya, for your excellent presentation on implants. So I think you have covered from A to Z of implants, starting from how it works and what are the types of implants and what is the content. And again, what are the indications and contraindication and how should you insert it? And then when the patient wants to remove, how should it be removed? And then the infection control program and all the side effects. So my one question is, some of the patients, they have intractable headache. When we even with a simple LNG IUS, they have intractable headaches and some visual disturbances also we have come across. So what do you think for those kind of patients?
Ma'am, initially we can give a counseling, but severe migraine with aura, when they are not able to tolerate, we can offer them another method of contraception also.
Yeah, it's always better.
Not able to tolerate, if it's very severe, they're not very tolerate, we can give them, it has got a basket of choices in contraception. If they're not able to tolerate, we can offer an alternative.
Have to remove it. So extensive counseling is the most important thing before inserting implant. But I think once inserted means it can be kept for some time. And I think that will be a useful one for the women who are seeking contraception. Dr. Jayalakshmi and Dr. Kartika, are you there? Any inputs you want to give? Dr. Shanti, Dr. Jayalakshmi? And in the chat box, yeah, nothing is there. But anyway, thank you, Ramya, for having accepted for this program in a very short notice and presented wonderfully. Thank you so much.
Pleasure is mine, ma'am. Thank you for the opportunity.
Thank you.
Thank you very much, Dr. Ramani, madam, for sharing this session. And thank you, Dr. Ramya, for the wonderful and elaborate talk. With this, we'll now proceed to the panel. I take pleasure in introducing our moderator for the panel.
Launch the question, ma'am. Gayatri, ma'am, shall I launch the poll question?
Yeah, you launch the question. We have a quiz question after this talk. Sahiti?
Shall I share my screen, ma'am?
Yes. Yeah, sure. Go ahead.
Ma'am, 1 second, ma'am.
Yeah.
Yeah.
Last 5 seconds.
Am I audible, ma'am?
Time up.
Am I audible, ma'am?
Yes. Yes.
Yeah,
Geeta,
we'll,
you are audible.
Welcome,
shall
Dr.
I
Geeta.
Ma'am,
introduce my
Gayatri ma'am will
panelists?
introduce
Excuse
the.
me.
Yeah, okay.
Yeah, sure. So shall we go on to the panel with Dr. Professor Geeta as the moderator with her team of panelists who are all experts in contraception. I take pleasure in introducing Dr. Geeta. Can we have her slide? Sahiti.
Madam, no issue, ma'am. I'm associate professor at Dindakal Medical
Dindakal
College.
Medical
ma'am.
College, Dindakal. She's a alumni of Madurai Medical College, and she did her MD from Stanley Medical College, and she's having a lot of paper presentations, and she's also been the recipient of the A.L. Modaliar Fellowship Award, and
Ma'am,
a
enough,
member
ma'am.
of all these societies, the important societies, and her contributions are always welcome. Over to you, madam. You can introduce your panelists and start the panel.
Thank you, ma'am. It's my pleasure to introduce my dear panelist, Dr. A. Mahalakshmi. She is my friend. She is Associate Professor, Government TNFOG Medical College. Welcome, Mahalakshmi. And the second panelist, madam, is also a senior person. She is Dr. Sujata Allegation. She is Professor of OBG, Tirunelveli Medical College. And Dr. Mahalakshmi, Consultant, Anirudh Hospital. Her special interest is in infertility and high-risk obstetrics. Dr. Shobana Priya, she is Associate Professor, Bharat Medical College and Hospital. Dr. Leena, she is Assistant Professor, ESM, MCH and Research Institute, Chennai. Okay, we'll move on to the panel now. Our panel topic is contraception. As we all know, we have to do a cafeteria approach for the family planning policy that offers a variety of contraceptive methods for individuals to choose their own options. We are supposed to give the basket of choices and they have to choose. This is cafeteria approach. We'll move on to the case scenario 1. I have taken only what we have encountered during our day-to-day practice. 28-year-old, the IT professional, planned a wedding next month, but she is pressurized that she has to complete her project early and submit within 6 months. She came to your clinic to know about the contraceptive choices. So, Dr. Mahalakshmi, are you there? Or any one of the panelists, what contraceptive advice will you offer for her?
Good evening, madam. Can you hear me, ma'am? Good evening, ma'am.
Dr. Shobana?
Yes, madam. Good evening, I'm Dr. Shobana, madam. First, at the onset, I would like to thank Sampath ma'am and Amni ma'am for this opportunity, and thank you, ma'am, Nita ma'am, for this wonderful session. And to start with, she's a 28 years old girl, and she needs contraception only for the short time. So for the short time being, the contraceptive choice, the first option could be an oral contraceptive pills, madam. It should be a combined oral contraceptive pill can be a better option for her. Provided there is no side effect, she can very well go ahead with yours.
Yes, ma'am. As she rightly pointed out, oral contraceptive pills is the first choice. Yeah, ma'am. Yeah. So we all know that our regular pills has 30 microgram of ethinyl estradiol and levonorgestrel. What is the composition of the low dose oral contraceptive pills?
And 20 microgram.
Yeah.
It has 20 microgram of ethinyl.
Yeah. List the absolute contraindication for use of the OC pills. Because when we counsel the patient, we should know the advantages, contraindications, and what are the side effects. Patients will ask us, what are the absolute contraindications?
Since it has an estrogen component, that there is always a risk for thrombotic event. So always try to give the pros and cons. Whenever we give the option of contraception, it is better we tell all the side effects as well as the advantages when giving them. let them take the decision of choosing the contraception. So our disadvantage or contraindication for using this combined oral contraceptive pill will be the present history of any thrombotic event, including the heart disease, stroke, any coagulation disorder, or deep vein DVT, pulmonary embolism, Apla syndrome, and liver disorder, and especially also when the breastfeeding is less than 6 weeks, we are not supposed to use the combined oral contraceptive. And in case of severe hypertension, where they can be expecting the thrombotic events.
So age of the patient is very, very important. Age more than 40 years. And if she has the, she's prone for thrombotic thrombosis, we are not supposed to advise OC pills. What are the important aspects of counseling? Aspects of counseling before commencing a woman on OC pills?
First, she has to take the pill regularly, and she has to start the pill on day one, and she has to follow it regularly at the right time, and not taking irregularly. When it is being taken irregularly, success rate gonna reduce and the failure rate is gonna increase. So we need to tell her about that. Taking the drug regularly at the right point, at the right day, will give her the maximum coverage for the contraceptive effect. And whether she is on any other drugs for any other medicines, any interactive medicines, we should ask before she comes for the option of COG.
Yes, ma'am. So what are the non-contraceptive benefits of using the pills? So not only for regularizing the cycles, this pills, it is used for primary dysmenorrhea, endometriosis. It is used for hypergonadotropic amenorrhea, for premenstrual syndrome. More than that, for endometrial and ovarian cancers, these help, and it will also improve the bone mineral density. Always please remember, ask them the questions whether they are taking any drugs. So how to commence and continue, you all know. She should commence on the first day. The days will be written in that. If she misses the pill, she can take 2 tablets. So more than 2 tablets, if she misses, she has to take a new pack. She should follow the correct procedure and inform the doctor. If she takes any other drugs, that will interfere with the contraceptive effects. So in between the spotting or irregular bleeding comes, what will you do? So reassure the patient. Anyone you want to take? Yeah, please proceed, ma'am. If she misses the pill, it could happen, and it is also because of the low estrogen content. And the using drugs which interact with the pill will reduce its efficacy. So always reassure the patient. So coming to the second question, the case scenario 2, if the patient is breastfeeding, she has delivered and we have given PP-IUCD. So our patients usually, after we put the postpartum IUCD, they will go anywhere elsewhere and they will remove the IUCD. And now she wants to have the contraceptive advice and she came to your clinic. What else you will advise? Most of them will not like this IUCD. Any other panelists apart from Shobana?
Yes, ma'am. I'm Dr. Mahalakshmi. Good evening, ma'am.
Yeah.
Yes, ma'am. I would like to thank Dr. Sampath Kumari, ma'am, and Dr. Ramani Devi, ma'am, for the opportunity. I would like to, yes, ma'am. Shall I continue?
Yeah.
Yes, ma'am. I would like to counsel the woman on the injectable contraceptives like DMPA, depot medroxyprogesterone acetate, 150 mg once in 3 months, ma'am. And for the postpartum mother, chaya could also be given.
Yes, ma'am. Since she is breastfeeding, this DMPA will not affect the lactating mother. It is ideal for the lactating mother. 150 milligram for 3 months, it can be given. IM injection. And what are the advantages of these injectable preparations?
Since it's given once in 3 months, she is not able, she can take it on a regular time basis, once in 3 months. And it also has some other non-contraceptive benefits also, like in severe endometriosis, dysmenorrhea, and okay. And also it is actually protective against cancers also, ma'am.
Yes, she did not remember and take daily as like oral contraceptive pills. And pills, we should not advise for a woman who has delivered. Only after 6 months, we should advise pills. And always IUCDs are better. If they don't prefer IUCD, it is better to go for this DMP injection and Chaya, as you told. What are the two non-contraceptive uses?
In endometrial hyperplasia, and it can also be given in endometriosis, dysmenorrhea.
Yes. So before any patient, when we advise this, they will ask what are the common side effects? What are the
Yes,
common
ma'am.
side effects for this
It
Antara?
most commonly causes irregular bleeding, irregular spotting, ma'am. And alcohol is a prolonged secondary amenorrhea. Patient also complain of headache, and they have increased risk of breast cancer, and they have loss of bone mineral density in some patients.
And also the common question they will ask when the return of fertility. So there is no issue in return of fertility also. What are the 5 contraindications for this DMPA?
Yes, ma'am. In the patients
As like
having
OC pills?
OC
Yeah,
pills
please.
also. Yes, ma'am. In patients having history of severe hypertension, diabetic complications, diabetic retinopathy, vasculopathy, and patients having history of breast cancer, or patients who are prone to breast cancer, and patients having vascular complications with symptoms of antiphospholipid syndrome, SLE, and patients having multiple risk factors for cardiovascular risk factors, or in case of unexplained vaginal bleeding.
Yes, ma'am. So how do you commence and continue this preparation? What day they have to start this? Any particular day?
It can be commenced within 7 days of the last menstrual period, ma'am, and it has to be restarted once in every 90 days. If she doesn't return after 7 days, it can also be given within 14 days. But if the mother returns after 2 weeks, we should start
Pregnancy.
Yes, ma'am. For pregnancy test, and if it turns to be negative, we can start it, and also we advise some barrier contraception.
So the grace period for injection DMPA is 2
7
weeks.
to 14 days. Yes, ma'am.
Yeah, 2 weeks. We have one more injection, norethistyrone enanthate, that is NET. That injection we can give IM every 2 months. The grace period is 1 week for NET. So we usually generally give this Antara injection only. Government supplies this Antara injection, and it is available in our private hospitals also. The additional contraceptive protection should be for the next 7 days. How will you treat irregular bleeding caused by DMPA?
We can give OC pills, ma'am. If the mother is comfortable with OC pills, she can continue the oral contraceptive pills.
Okay. So we'll move on to the next case scenario, number 3. A para 1 live 1, Mrs. X, 3rd postnatal day, planned discharge from the postnatal ward. So what are the contraceptive advice you will give for her? She has not had a postpartum IUCD. What are the advice? What options you will give? Generally, during the antenatal visits itself, we are giving a contraceptive advice. I think all are giving during the antenatal period itself. What advice you will give after delivery when we go for rounds in the postnatal ward?
Since the mother is in the postnatal ward, we can easily counsel her for the copper IUCD, ma'am. And also, if the mother is willing, we can go for hormonal IUCD or implants also.
Yes, we have 10 years copper T, 380A, and 5 years, anything, whichever patient prefers, we can give. List 2 hormonal contraceptives which do not interfere with lactation.
Ma'am, progesterone implants and Mirena IUCD.
Yes, ma'am. What are the advantages of using a copper IUCD as a method of postpartum contraception?
Yes, ma'am. Copper IUCD
Since
is
it
a
is a copper IUCD,
Madam, please proceed, ma'am. So post-placental IUCD, we insert within 48 hours of delivery, not more than 48 hours. If more than 48 hours means after 6 weeks only, we are supposed to insert because of the risk of perforation. So the advantages are it does not interfere with breastfeeding and it does not increase the risk of thromboembolism. Fertility returns soon after the IUCD is removed. So when can a breastfeeding woman be commenced on OC pills? As you all know, this is after 6 months. What is the best method of postpartum contraception?
I would opt for property insertion, madam. So it can be very well inserted immediately after delivery as a post-placental, or at least within the 48 hours as postpartum IUCD, or if it is variant concurrent property insertion, that we can do it. So the hormonal side effects are less, and patient need not take the pill or she need not remember the pill daily to us.
Yes, definitely.
Injection, the pain of injection, once a one-time procedure. If she take it, it will be like for even up to for 10 years, maximum of 10 years, she can have the benefit. And whenever she wants to resume the fertility, she can remove it and resume her fertility as well.
Yes, ma'am. We should keep the patients, tracking the patient, and we should call them for follow-up. Generally, we discharge them and we'll ask them to come for review after 15 days. We should inform them that they should feel the thread and we should check the copper T whether it is in position, and we should keep them in follow-up. This is the eligibility criteria for PPA-UCD. Immediate post-placental, less than 48 hours, we should insert. This is post-placental for normal delivery, or intracesarean copper T we used to do. Under aseptic precautions, we should not forget that. So coming to the next case, Mrs. Y, para 3, live 3, not sterilized, came with her husband to gynec casualty for advice on emergency contraception. She has not sterilized still. She's not willing for. She came for an emergency contraception. What's available? Anyone who can take up?
At this junction, we can use this opportunity. We can use this opportunity to give a counseling for a permanent sterilization if we offer it. And then as a emergency contraception, we can give IPIL if it is available. And it can also be given a high dose of combined oral contraceptive pills can be taken as an ST regimen. And we can also insert property insertion. Yes, and always we have to tell her that if she misses her period, that cycle period, she has to go for an UPT and root pregnancy.
So levonorgestrel, 1 tablet, 1.5 milligram or 0.75 milligram, 2 tablets. It is available easily, or else she can go for, as you said, she can go for 4 stat tablets of oral contraceptive pills, followed by 4 tablets after 12 hours. And then copper IUDs up to 5 days can be given. Within 48 hours is ideal, as early as possible of unprotected intercourse. So mechanism of action, all of you know, prevent implantation, prevent fertilization. It thickens the cervical mucus and it interferes with corpus luteum function and luteolysis. So who can provide this emergency contraception? Not only doctors, so nurses, midwives, pharmacists, chemists, health and family welfare assistants, community health workers, anyone can issue this. What are the advantages of EC pills? So it is safe, effective, easy to use. It can be used by women with contraindications of OC pills. It do not require any physical examination. Can be taken at any time during a menstrual cycle after an unprotected intercourse. What are the misconceptions about EC pills? Can anyone take?
EC pills doesn't cause any abortion or it doesn't cause any harmful fetal side effects, ma'am, if pregnancy occurs also.
Yeah, that is very, very important. As you said, even if she is pregnant, please assure them that nothing will happen. How to manage failure of EC pills? So you always when you give, tell them that there is a possibility of pregnancy advise a pregnancy test to confirm. If she's pregnant, nothing to worry. If she wishes to continue, she can continue the pregnancy. So next case is para 1 live 1 abortion 1 MMA kit taken, and after 2 weeks repeat scan done, uterine cavity was empty. She is planning her pregnancy after 2 years. In between, what choices can be offered to her? She wants pregnancy only after 2 years. Yeah.
As a post-abortal contraception and wanting to postpone for 2 years, copper-T can be inserted. Even if it is a first trimester MTP, copper-T can be inserted along with the following an abortion. If she had an MMA, probably with the next cycle she can come and get her copper-T inserted.
Yeah.
So if she can, if she is not looking for already given the choices, the benefit of those. So if she is not looking for copper-T, even anti-injections or Chaya can be also.
Yes, madam. So coming to the last scenario, contraception in midlife, 41 years, para 1 live 1, IVF conception, who has severe mitral stenosis delivered 6 weeks ago. What is the contraception of choice? If husband is not willing for vasectomy, which is the more ideal thing?
And progesterone implants and
Yeah. So 42 years uncontrolled diabetes under treatment. What is the contraception of choice? We can give copper containing IUCDs and LNG IUDs. A 42-year-old para 2 live 2 not sterilized came with complaints of heavy menstrual bleeding. UPT negative endometrial sampling done results showed simple hyperplasia. What is the next line of management?
Since she's
so this will be for her gynae complaint.
So, hormonal IUDs are better, especially this levonorgestrel. So what if an adolescent girl comes to you, what choices you will offer for the adolescent girl regarding contraception?
So again, to start up with, give them the basket approach, give them the choice of combined oral contraceptive barriers, and then also the barriers, and also give her the failure rates of as well as, and progesterone only pills also can be given as the next option. The first option I would request you would combined oral contraceptive pills, and next is barrier method.
Yes, ma'am. Thank you, all my panelists. You have done my job easy. Ma'am, can we wind up, ma'am? Anything to discuss?
So we have, so any juniors who have query, I would have to add 1 point, madam. Any juniors who really every time we are in a OP, if we have any queries regarding what to choose, we have an app from the WHO contraceptive bill. So we did not feel we did not search for the books or net at that time. So we can just go for that app, click on what is the criteria, and then we can choose some just for the benefit of the junior colleagues. I'm just adding on 1 point. The usage of contraceptive, we can use it as an app. So the app is available. We can have it in our own mobile itself.
Yes, ma'am. Anybody wants to add anything?
Geeta முடிச்சிரியா?
Thank you so
Yeah,
much.
ma'am. Over, ma'am.
For the opportunity.
Gayatri? Geeta, question கொடுத்தியா Geeta?
Yes, ma'am. Yes, ma'am.
If no doubts means we can post the question. Ena Geeta, okay va?
Yes, ma'am. If she is a multi-para, para 3, live 3, always you counsel for sterilization because higher order birth, it's one of the cause for maternal death, the postpartum hemorrhage, maternal death. Always advise sterilization. As many heart patient we have to counsel the husband, talk to them for take time and talk to them for vasectomy. Nowadays, they have started accepting that. இப்ப கொஞ்சம் difference தெரியுது. And government setup la இருக்கவங்க நாங்க ரெகுலரா அந்த போஸ்ட் பிளசன்டல் PPICD ஃபாலோ பண்றோம். 100% கவர் பண்றோம். சுஜாதா மேடம் இல்லன்னு நினைக்கிறேன்.
அது நிறைய இடத்துல பிபிஐ யூசிடி ஹிஸ்ட்ரோஸ்கோபிக் ரிமூவலுக்கு பிரைவேட் ஹாஸ்பிட்டல் போறதா சொல்றாங்களே கீதா, கரெக்டா?
மேடம் இங்க போட்டு விடுறோம், அப்புறம் அங்க போன டிஸ்சார்ஜ் ஆனோன்னு போய் எடுத்துட்டுறாங்க மேடம்.
இல்ல
அதுவும் நடக்குது.
அது மயோமெட்ரியத்துல போது ஹிஸ்ட்ராஸ்கோப் வழியா தான் எடுக்க முடியுதுன்னு பிரைவேட் டாக்டர்ஸ் நிறைய பேர் கம்ப்ளைண்ட் பண்ணிருக்காங்க. அது கேட்டேன். அங்க
இல்ல மேடம்,
இல்ல
அந்த மாதிரி எனக்கு தெரியல.
ஓகே,
எக்ஸ்பல் ஆகுது, எக்ஸ்பல்ஷன் ரேட் இருக்கு, அவ்வளவுதான்.
சரி சாகிதி, யூ கேன் போஸ்ட். சோபனா, ரம்யா, ஜெயலட்சுமி, மகாலட்சுமி
Thank you
வரல.
so much, ma'am.
தேங்க்யூமா. சோபனா, நீ இப்ப இதுலதான் இருக்கல்ல?
பாரத்ல இருக்கேன். செகண்ட் டு செகண்ட் பண்றோம்.
சரி, ஓ போயிட்டியா கவர்மெண்ட்டுக்கு?
பாரத்னா சேலையூர்ல இருக்கே அதுவா? சேலையூர்ல. அது எங்க வீடு அங்கதான். செம்பாக்கம் தான் எங்க வீடு, அங்கதான்.
ஓகே, சரி.
Should I launch the question, ma'am?
Yes.
Okay, ma'am.
Geeta, you can read.
Yes, ma'am. 2 combined oral contraceptive pills, contraindications are all except a high risk of venous thromboembolism, uncontrolled hypertension, anemia, postnatal less than 3 weeks. Single choice you have to answer. This is poll.
Yes, ma'am. Last 5 seconds.
நம்ம பண்ணக்கூடாது.
Only delegates are eligible, not the faculties.
அப்படிதான் என்னோட பிஜி வேகமா கிளிக் பண்ண போறேன்.
Over, ma'am.
ஓவர். சரி, ரெண்டுத்தோடய ஆன்சர் போட்டு அடுத்தது காயத்ரி வெல்கம் வோட் ஆஃப் தேங்க்ஸ் சொல்லிடுவா. நல்லா பண்ணா கீதா.
தேங்க்யூ மேடம்.
அதனாலதான் சரி இன்னொருத்தர் போடணுமா வேண்டாமான்னு யோசிச்சுட்டு இருந்தேன்.
மேடம் இததான் நாங்க டே டு டே பாத்துக்கிட்டு இருக்கோம். ஈஸியா இருந்தது.
பேனல்ல வந்து கரெக்ட் டயத்துல முடிக்கிறது ரொம்ப கஷ்டம் தான்.
அவ முடிச்சிட்டா. சுஜாதாவா?
That requires a special applause, ma'am. All the panelists, moderator, everyone. Because we didn't really beat around the bush.
Government setupல இருக்கிறவங்க, அதனால they know.
மேம் அது இம்ப்ளான்ட்ஸ் ரொம்ப நல்லா இருந்தது, நல்லா பண்ணிருந்தாங்க.
அது கான்ட்ராசெப்ஷன்
எலாபரேட்டா நல்லா இருந்தது. இம்ப்ளான்ட் எவ்வளவு நேரம்
அவைலபிளா மேடம்? இப்போ அவைலபிளா மேடம்?
அது வந்து சென்டர்ல மட்டும்தான், எல்லா இடத்துலயும் கிடையாது. அது
மேடம் if I may add மேடம், இம்ப்ளான் வந்து இப்போ கவர்மெண்ட் ப்ராஜெக்ட் வந்து இருக்கு மேடம் ஆக்சுவலா. சோ வந்து இம்ப்ளான் இஸ் அவைலபிள் இன் 2 districts மேடம், தர்மபுரி டிஸ்ட்ரிக்ட் அண்ட் சென்னை டிஸ்ட்ரிக்ட். சென்னையில வந்து IOG KGH
மென்ஷன் பண்ணாங்க. she did mention that in her speech.
ஆஸ் மேம் அதான்.
IOG ல தான் அவைலபிள், வெளிய கூட கிடைக்குதா?
வெளியிலயும் கிடைக்குது, பிரைவேட் ஹாஸ்பிட்டல்ஸ்லயும் போடுறாங்க. IOG KGH வந்து சென்டர் இன் சென்னை மேடம். தர்மபுரியில வந்து மெடிக்கல் காலேஜ் அண்ட் தர்மபுரி GH வந்து சென்டர் மேடம். தேர் ட்ரைனிங் டாக்டர்ஸ் ஃபார் எம்ப்ளாய்மென்ட் இன்செஷன் அண்ட் ரிமூவல் தனியா கவர்மெண்ட்ல 2 days ட்ரைனிங் ப்ரோக்ராம் இருக்கு மேடம் உங்களுக்கு.
சரி சரி, ஓகே. அது வந்துருச்சுனா பெட்டர். அடலசன்ஸ் எல்லாம் கூட வில்லிங்கா போடுவாங்க.
நாங்க போட்டுருக்கோம் மேடம். we have given for unmarried girls who are 18-19 years old because they want they think it's comfortable.
அரவிந்த் பாக்ஸ்
18 years மேல தான் மேடம், 18 years மேல தான் மேடம்.
18 குள்ள போடினா பாக்ஸ் ஆக்ட்ல மாட்டிப்பேன். 18
மேம், நாங்க எப்படி மேடம் 18 குள்ள போட முடியும்? நாங்க எல்லாரும் ஆதார் கார்டு வச்சு we are getting everything properly scrutinized and then only we are giving.
Even the emergency contraceptive pills for girls less than 18 years.
Yes madam, yes madam.
Prescription கொடுக்க கூடாது. இங்க போய் வாங்கிக்கோ அங்க போய் வாங்கிக்கோன்னு சொல்லலாம், அவ்வளவுதான்.
Yes madam, we have everything ma'am. Yes ma'am, thank you madam.
Thank you. சாகிதி ஆன்சர் போடுறியாமா ரெண்டு क्वेश्चनக்கும்?
Yes ma'am. Just 1 second ma'am.
இல்லனா காயத்ரி வோட் ஆஃப் தேங்க்ஸ் பண்ணனும்னா போடு. இந்த டெலிகேட்ஸ்க்கு யார் யாருக்கு வந்து அந்த gift வரலையோ தயவு செஞ்சு எனக்கு சொல்லுங்க. என்னோட நம்பர் 9888133300.
Yes ma'am.
Next plan on. Okay. Then second is Vidya Salem. சரி, இத குரூப்ல போட்டு ரெண்டு பேருக்கும் வரும் gift வந்து it will come to your house with the phone number. Yes, Gayatri, now you can, our MOC, Dr. Gayatri will deliver the vote of thanks. Contraception na Ramya illama kadiyadu. Ipa Geetaum.
And true what madam said, The faculty today have been excellent, including the Yuva faculty, who have all done real justice to their topics. And yes,
including Yuvas are best always.
Yes, ma'am.
படிக்கிறாங்க படிச்சு சொல்றாங்கல்ல.
Ma'am, இல்ல ma'am, இவங்கெல்லாம் they are professors தானே ma'am. Just they get to be in that group because they are still young. Younger age at achievement. 40. Yeah.
Ma'am, whatever it is, there is no age for reading. Over topic கொடுக்கும்போது படிக்க தானே செய்றோம் ma'am. It's an opportunity to read and enrich knowledge.
This thing as Yuva, usually the younger people don't get real good opportunities because we have the seniors there. So when we put it as Yuva, we are able to give it for younger people at very good forum. So it's a very good initiative.
நான் வந்து ஆதார் கார்டை கூட வேணா வெரிஃபை பண்ணிப்பேன். It is less than 40. Okay, Gayatri, deliver the word.
I really thank all our faculties, our panelists, our Yuvas, our judges for being with us in this beautiful webinar on contraception, which is an everyday practice, be it the government sector or the private sector. And we had a lot of our knowledges updated as well as the revised, revisited. Thank you very much for being with us today and making such wonderful preparations so that the delegates do get the best of it. I also thank the our president and secretary and all the office bearers of TNFOG for bringing this and making sure that this happens each and every month in the best of its as a best of its kind. And many thanks to all the delegates. Without them, there is no conference and there's no meaning for any webinar. So thank you for joining us and trying to learn all these things and being with us throughout all our episodes and webinars. Thank you, Shri Priya, for being the event manager, as effective as always, and Sahiti and the Shield for your technical support, and God Almighty for and my prayers and my gratitude towards God Almighty for blessing us with all these blesses all these years. Thank you.
Thanks to Dr. Atul Munshi, chief guest.
Chief guest, definitely. Sir was ahead of time with us. He really, he really enjoyed the first few talks also, and he had posted some messages also. Thank you very much, sir. Sorry for missing that.
Okay, Mahalakshmi கூட செங்கல்பட்டு தான் Gayatri.
Oh, okay.
அவ இப்ப தர்மபுரி பக்கம் போயிட்டா. Okay, thank you, Sahiti, Sri Priya, Geeta, Ramya.
Thank you, ma'am. Thank you so much, ma'am, for the opportunity.
On behalf of Shield Connect.
Thank you so much.
Thank you, madam. Thank you so much, madam.
Thank you, Jayalakshmi. Thank you.
Thank you, madam. Thank you so much.